Perfect. So today we are talking about renal imaging and function. It is quite a heavy topic from the clinical side, again, not so much from the radiopharmacy side. So I will just give you some basics, and then from there on, of course, your clinical knowledge will contribute to the rest. So let's get started. We will discuss agents of GFR agents, tubular secretion agents, tubular fixation agents, as well as not really focusing on renal blood flow. The reference from which I got this actually went quite extensively into renal blood flow measurements with particles, labeled red blood cells, and radioactive gases, but it's not really clinical practice, so I didn't think that it would be of value to go too much into renal blood flow agents. However, I know that it's possible to do a phase scan of the kidneys as well and first image the renal blood flow as well. But I've also talked to my clinical colleagues and they said it's really not that important, because if you look at the other agents, it will also give you an idea about the health of the kidney renal blood flow. So in the end, I will just focus on glomerular filtration agents, tubular secretion, and tubular fixation agents. I think that is good for basics. However, if you want me to go into the rest on a later stage, please feel free to ask. Let me just turn off my video. I hope that it wasn't in there, especially for YouTube. But anyway, this is informal classes, as we all know. So you have to choose the correct radiopharmaceutical for what you want to image in your clinical questions. So there is a lot of clinical questions. Like we said, perfusion, that's the renal blood flow that you can do maybe early on imaging with MAG3 and DTPA, morphology with the DMSA, obstruction, MAG3, DTPA, relative function with all, and GFR quantification specifically with DTPA, as well as ERPF with MAG3 and EC. So this is just the technetium agents. Of course, there is other options, and I will go into that as well, what we have used in the past or what you can still use. Non-imaging as well as imaging, but these are the technetium tracers, and you should know what you want to do and which one to choose then. So firstly, into some pharmacokinetics, because I think renal function, it's one of the things where we use pharmacokinetics the most, or the most direct use of pharmacokinetics and the compartmental models. So in pharmacy, you have, for pharmacokinetics, you have the one compartment model and two compartment models. You can also have three and more, but for the sake of what we want to do with the kidneys, we will focus on one compartmental model and two. If you want to look at an example of a three compartmental model for pharmacokinetics, MDP or bone tracers are a good example of that. But for a one compartmental model, ideally you should be administering your radiopharmaceutical directly into the central compartment, and it should then be excreted linearly as just as a logarithm of the concentration, so that you can have a straight line. There is no accumulation elsewhere, so you know that your excretion is directly in proportion to what is in the blood, and from that you can then take blood samples, also measure what is excreted, and also use imaging then to plot the kidney function, and then you know if there is obstruction or any malfunction of the kidneys. In your so the ideal GFR agent, of course, will be a one compartmental model without any other surprises. Your two compartmental model is where you inject your radiopharmaceutical in the central compartment, and then it distributes to any other peripheral compartment. This could be soft tissue, or it could be actually binding to plasma proteins or anything else that takes it out of the blood pool, and also slows the elimination. So you will not have a linear relationship, and this will influence your calculations when you do kidney function. Here on the bottom is a nice reference on the internet. You can go look there, and a lot of pharmacokinetic explanations are there, but this helps you to determine then all the calculations of kidney function. So of course, first we will look at the ideal characteristics of a GFR agent. It should be relatively easily filtrated, or not, it should just be filtrated easily. Like we said, it should be injected in the central compartment and then excreted logarithm with concentration to the blood. So whatever is filtered out should be no barriers towards filtration. So it should also be uncharged or positively charged to be excreted easily. It should be stable because you are following the radioactive component of this radiopharmaceutical. So if the radioactive part is released from the carrier that is filtrated out of the kidneys easily, then you have a problem because your radioactive part will not be filtrated at the same tempo than your carrier. So then you get false measurements. So stability of these radiopharmaceuticals in vivo are one of the most critical components. It should be completely filtered by the glomerulus and there should be no reabsorption. We want the one compartmental pharmacokinetics. So what you put into the central compartment should be excreted directly out of the kidneys and not distribute any other place in the body. It should have similar kinetic properties to aniline because this is the gold standard that is used or was used in the past for GFR function. So just to be able to compare with that, it should be equal to aniline. And there should be no protein binding of the radiopharmaceutical. Because as you know, if it binds to the proteins, it is delayed excretion and it stays longer in the blood and then you get false measurements. So we can have plasma clearance and urinary clearance for GFR. So with radiopharmaceutical, we mostly use plasma clearance. We do not take samples of the urine at certain time points and then measure, but you could also do that, of course. So plasma clearance is always indirect. It is the disappearance of the marker from the plasma, taking into account that it has one compartmental model pharmacokinetics. So we assume you inject it into the central compartment, and what is not in this plasma function is actually excreted already. And that's how you can then quantify GFR measurements. So it's not cleared at certain time intervals, and you then calculate plasma concentration versus time, taking into account the starting amount injected into the patient. Urinary clearance, on the other hand, is directly the measurement of renal function, and you can then measure all of the activity excreted in the urine. But it's just much more difficult to do properly, and it's just a lot of effort and patient inconvenience. So we use the plasma measurement. So as I said, instability is really important. So we will spend a two slides on that. So there's two options, transchylation and transmetallation. They basically do exactly the same thing, but you should know the two differences. So transmetallation is where the radiometal in the radiopharmaceutical is displaced by another metal. So there is another metal in the body that has a higher affinity for our radiopharmaceutical, and it kicks out the radionuclide and form um, another compound that's cold. So your radionuclide is freed and it's in the body, and your pharmaceutical is linked to a cold metal, and that then distributes with the radiopharmaceutical. So this is something we don't want, and your GFR agents should be stable according to this. And indeed, DTPA and EDTA is very stable. The other instability is transchylation. So this is where your radionuclide is actually taken off by another entity in the body, like a protein or something that is has more affinity. So it's normally things like transferrin or all of those. So you want your radionuclide to also not have higher affinity for anything in the body compared to the chelator. So this chelator radionuclide combination should be very stable. I use chelator or ligand interchangeably, but it's a molecule that catches the radionuclide and has it fixed really well. Like we said in the past, chelator is the Greek word for claw, so that's why we use the word catch, but it's of course much more chemically intricate than that. But yeah, so if the radiopharmaceutical binds on proteins, this is now the protein binding, it can really take the radiopharmaceutical out of the circulation, and then it's not actually excreted out of the body. So we can have two things. We can have a radio. So most of the radiopharmaceuticals we use currently has some protein binding that we have inserted in our calculations. So there is, for instance, technetium DTPA has a 10% binding to these proteins, and we know of it. So all of our calculations that we have naturally accommodates this. So firstly, you don't want increased binding of the radiopharmaceutical, because if you have increased binding of the radiopharmaceutical, it will not be filtered out by the glomerulus, and then you will have a false bad uh, result. So it will be less GFR function than what it actually is. On the other hand, if you have drugs like metformin or furosemide that actually likes binding to proteins more than the DTPA, it can displace the normal 10% that is bound to these proteins, and then that can lead to increased GFR measurement, and which is not the actual function. So there is some drug interaction here that can make you overestimate GFR function, and then there's also the fact that if you have a radiopharmaceutical that binds more, it can underestimate GFR function. So you should know the constraints of protein binding and also special patient requirements according to that. So only the free fraction of the radiopharmaceutical is filtered out by the kidneys. Great. So here is a summary of GFR agents and the differences. And you can see that protein binding is approximately 10% in all EDTA, DTPA types of radiopharmaceuticals. Iodine 125 iofalmate also has a sort of 10%-ish binding, and there is therefore no really clinically significant differences between these agents. In the past, people were a bit scared of using technetium DTPA instead of the good old chromium 51 EDTA, but with more research came more knowledge, and they also saw that it's really not clinically significant, the differences between these two. What is good of technetium DTPA is that you can do both the plasma sampling, but also if you inject at a higher dosage, you can do a renogram. So that's also really helpful. So reactor-produced chromium EDTA is very expensive. You have to order it, and it doesn't offer you the imaging capabilities. Technetium DTPA, very easy, cheap to make, and so on. But you have to be sure that you do correct quality control and that your technique of labeling in the lab is good. But it's also, on the other hand, really easy to label. So there's no tricky business going on there, and you can get really a good labeling and do a good procedure. Gallium EDTA offers you the option of 3D renal imaging and PET if there is a clinical need. I've never heard people complain that they really need PET for these type of investigations, but it's a viable option, and if you already have a gallium setup, it's really easy to do. And then there is a new PET tracer. It's a sort of glucose analog, and it has, very interestingly, a near 0% protein binding. So this is something that you also have to take into account. It is cyclotron produced, and it is done by automated synthesis. So we will quickly discuss that too. So the radiolabeling of technetium DTPA is, like I said, quite simple. You add your activity in 5 milliliters, you let it stand at room temperature for 15 minutes, and then you do your QC. So there's really nothing serious about radiolabeling of technetium DTPA. It's one of the easiest to perform. Then you will, of course, draw your patient dose, And then you will also make up a standard of 1 milliliter, and then you will use that in the end to do your calculations and your counting on your machine, because you also have to measure on a gamma counter. So you will have to translate the injected dosage to counts and then see how much these counts clear out of the patient. So the calculations behind this whole technique is quite tricky and should be done. And most often people have a automated spreadsheet where they read in the values and calculate. Great. The radiolabeling of gallium EDTA is also very simple. So you just add your gallium to the mixture. You have 1.5 milligrams of EDTA that you can buy. There is no kit, but you can buy this EDTA quite easily. It's available. It's a chemical. And then you incubate for 10 minutes at pH 5, and then you can do your QC. And I did add for you a reference if you want to have a look. It's really one of the easiest procedures to do, and it labels extremely well. Then next we will go to tubular function agents. This is just to study renal morphology. These agents are excreted by both glomerular filtration and tubular secretion, so there is no specific only mechanism, so it's like a dual mechanism. And you use mag-free, and here I can tell you a little bit more of a more tricky radiolabeling procedure. So you have a protective group on your mag-free, and you have to first add pertechnetate. There is tartrate as an intermediate ligand in your mixture. So you add your pertechnetate, it forms technetium tartrate. Then you have to add air. So this is one of those that you actually add air to remove all the oxidative agents, the stannous ions out of the mixture. You have to have a really an environment that is not reactive anymore. It will not reduce anything anymore. So first, we have a protected mag-free. You add your pertechnetate. It will not react to your mag-free in the beginning. It will form an interaction with your technetium, your tartrate to form technetium tartrate, which is your intermediate ligand. Now you remove all the excess tin in your mixture so that it doesn't react anymore. And only then you deprotect the mag-free and make it active so that it then takes the technetium from the tartrate and form technetium mag-free. You have to heat it up for 10 minutes to ensure that it deprotects completely. Otherwise, you will have lower radiochemical yield. You will have some technetium tartrate in your mixture left. And then it's important to also allow for 15 minutes cooling down, because if you take your QC sample earlier, it will not be of good radiochemical yield because this reaction hasn't completely formed yet. And in the end, you have this technetium mag-free. So it's one of the more trickier things to label. There is two methods. One works by pH, one works by heating up, but they are both the same. So you need to understand that in the lab, you have to follow the instructions directly as the manufacturer said step by step. It's also important to note that the quality of the technetium eluate that you add to this mixture is really important, since it's such an intricate labeling process. If you use an old eluate or from a generator that has not been eluted in the last 2 days, then you will have some trouble. Great. The next that we are going to look at is your technetium DMSA. It's just to do renal cortical assessment. It is just relative to renal tubular mass, and it's not a measure of a specific parameter. So it's just anatomical imaging, basically. And I just pasted a picture of a horseshoe kidney here, as well as a displaced kidney, just for interest. And this comes from this reference. So this is also interesting from a radiopharmaceutical perspective, because you have two forms of this agent. So you have the technetium pentatate DMSA, and then you have the trivalent DMSA, and it depends on the acidity level at which you label. So again, follow the instructions of the manufacturer, and if they have an additional buffer vial there, then you should add it at the end, because we normally label acidic DMSA. So this is for kidney imaging. So you will label at a lower pH of about 2 to 3, and it will form this complex at a lower oxidation state. This will then accumulate in the kidneys and is suitable for kidney imaging. The buffer is added to the package because after labeling, you can bring the pH up to normal pH 7 level for patient use. Otherwise, the patient will complain and get some irritation at the injection site. The pentavalent technetium 99M complex of DMSA is rapidly excreted by the kidneys because it looks like a phosphate ion and it's taken up by metabolically active cancer cells. I've not seen this used in the clinic, but you can label it like this, and there is people still investigating it for cancer. So here is the exact same patient. The one got the kidney. The one image was taken with the technetium free as a technetium tetravalent DMSA. So you could see no cancer on this patient, and then it was all, of course, which they didn't show, accumulated by the kidneys. And then on the right, you have the same patient with the DMSA at the pentavalent state, and there you could see that the tumor is visualized. And of course, it's rapidly excreted by the kidney, so you will get no accumulation. So if the pH that this is labeled at is wrong, if there's something wrong with the kit, you will not get accumulation in the renal cortical imaging area. So it's always important to do your QC. Yeah, so the labeling process, again, just quickly. To make the renal one, you will add the DMSA at acidic pH. It is in the kit vial formulation already. You incubate for 10 minutes and then you do QC, and you will see for the same, the methyl ethyl ketone solvent, you will see that the DMSA comes out at the origin and your free protectate in front. It's exactly the opposite for the one labeled at pH 9. So you add a buffer to buffer it to pH 9, and then it looks completely different with your free protectate coming out at the origin and your DMSA at the front. It's also a very interesting article that you can have a look at. So yeah, your QC is of course really important, because if something goes wrong in the labeling for the kidney one, you will see a higher peak at the front, and then of course that's also trouble. Then finally, we will quickly look into pharmacological interventions. So if you do diuretic renography, you assess the urinary tract obstruction. So you want to do the normal renogram, and then after some time you administer your diuretic, and then you will see delayed excretion. So there is a difference between the normal pattern, the one that has a non-obstruction, and then the obstruction. So if there is if there's obstruction, the administration of the diuretic will not change the renogram. So we use furosemide that works at the thick segment of the ascending limb of Henle, the loop of Henle, and it competitively inhibits chloride binding, and so the sodium ions is still in the lumen, and that increases the excretion of water. The next one is the caterpro renogram, which is an ACE inhibitor. And this will also change the hemodynamic significance of renal artery stenosis and renovascular hypertension. So you will then also see the differences between the kidney functions. This is also quite an important investigation to do. It has significant implications for the patient management thereafter, and there is also a reference for you to have a look at. I didn't want to redraw how ACE inhibition works, but there is like this whole, from the same article, this whole explanation. and just how the blood pressure is then increased, and you get normalized renal perfusion in the affected kidney, but it gives you hypertension, and this is the whole mechanism of action. I want to thank also again Nastasha for contributing some slides. Also, I'm using by render. I hope this was interesting and that you got to see new things. And then I just want to say next week I will be in the lovely Vienna at the ENM, so I will not be able to give you a class. But yeah, you're welcome to